Okay, well, welcome. Thank you very much for coming. This is the 15th summer of these Healthy Living lectures, well over 100 speakers on various topics. I'm Mike Powers. I'll be introducing tonight's guest. Important to remind people that these lectures really, I think, are largely due to Michelle Bartlett's vision, pulling the community and the university together. However, that relationship goes back to 1917. Lots of wonderful examples of a well-united community and university. And Michelle, with programs and partnerships and camps and travel and lectures, it really has done an outstanding job. From a health perspective, the university community partnership is historically demonstrated in the events of 1967 and the 100-year flood that forced the community to rebuild its hospital. And UA President William Wood headed up the building of that hospital, debt-free. Effort was effectively supported by leading citizens like Harry Porter, University of Alaska Engineering Professor Bill Mendenhall, building contractor Con Frank, labor leader Corny Cornfine, and we have Jeff Cook here, who has been a big part of that over the years. And also, I think of people who've worked in the university and have been very active with the hospital. Regents like Karen Perdue, former Mike Kelly, currently now Scott Bell, head of the foundation, took Jeff's spot as he stepped back into an emeritus role, and Kari Burrell. And they were all of these are both immersed in the university and the hospital. Michelle has kept the university tradition going with many robust programs. Tomorrow night, Claudia Isle, Associate Professor of Biology, speaks here as part of the Discover Alaska component of these weekly sessions. Her subject, When the Muskox Comes to Town, Urban Muskoxen in Nome. Thursday night, Music in the Garden, features Deja Vu at 6 p.m., Sourdough Risers at 7:30 p.m. So with that, let me introduce Dr. Christopher Gay, board certified in pain management by the American Board of Medical Specialties, board certified in anesthesia by the American Board of Anesthesia. Board certification, of course, requires passing rigorous national exams, ongoing education, verifies a deep expertise in a particular field, medical field. In this case, Dr. Gay's specialties are pain management and anesthesia. It's strictly a voluntary pursuit for these credentials, very much peer respected. So double board certified physician is a wonderful addition to the medical community of Fairbanks. Dr. Gay earned his MD from the University of North Carolina School of Medicine at Chapel Hill, fellowship trained in pain management at Columbia University, New York Presbyterian, New York City, collaborator with osteopathic medicine, which may make for a good question here, physical therapy, and if needed, surgery. Also, an amateur musician playing blues, jazz, and gospel by ear. And we may have to get him into Music in the Garden next year.
Sure.
They think less.
Sign me up.
But with that, please welcome Dr. Christopher Gay for tonight's Healthy Living Lecture.
Thank you. I actually had a slide introducing me later, so we'll be able to skip over that one pretty quickly because he did such a thorough job. Can we go ahead and pull up the first slide that we have there? All right, and we'll get on presentation mode. All right, so this is everything you know. So we're going to skip past this slide and go into the next one. So today's roadmap, where are we going to go? All right, so we're going to start off meeting me, which you just kind of did, so hello. Then we're going to talk about what is interventional pain management. What do we do? What do we treat? Who should come to see us? And to really understand that, we really need to understand what is pain, right? So it's not just a simple thing that you think it is. There's actually purposes for it, and sometimes there's not purposes for it, and that's usually where I come in when the pain is sticking around, and we need to figure out what it is. We'll talk about some common conditions that might affect you or someone you know, or if it doesn't affect you now, it may affect you later. If you don't continue to come to this Healthy Living series and learn the things to do to keep it from affecting you. And then we'll talk about some treatments, some things that you may have heard of, cortisone shots and things like that, and then some things that you probably haven't heard of. And then we'll wrap it up with any questions that you may have. But feel free, if there's something on the slide and you have a question, unless they make me, I won't stick to the script. I'm happy to answer some stuff in between. So, next slide, please. All right, as I told you, so I grew up in North Carolina. That part he may not have had that I grew up there. So I grew up in eastern North Carolina, a town about 5,000 people, suitably named Farmville, North Carolina. There wasn't much else out there but farmland. So I am from the country. Every now and again you may hear my accent come out. So from there I did, Duke for undergrad and Chapel Hill for med school, and then I went on to New York. I said, I really like North Carolina, but if I don't leave now, I'm probably never going to leave. So I'm going to go out for a few years, do residency, then I'll come back and live in Charlotte, North Carolina, beautiful place. And somehow, once we finished in New York, we decided to make a pit stop in Virginia. And I say we, me and my wife, she's a gynecologist as well. And she was from Pennsylvania, so that's about halfway in between the two. So that's how we ended up in Virginia. So we'll stay here for a few years, and then we worked there in about 4 years, and then I got an interesting ad from Alaska, and I was having some changes at my current practice where they were purchased by private equity. So I don't know if any of y'all are in finance, but you know what happens after that. They really change what you can do and how you can treat patients to try to save a dollar. And so I was looking for a change, and it just so has it that the chair of neurosurgery from my medical school at Chapel Hill had moved to Alaska 10 years before. And I thought it was the strangest thing in the world. I was like, who would ever want to move to Alaska? And so I was like, well, if he's still out there, it's probably a good thing. So I looked him up, and he was still out there 10 years later. Called him up, and he said, hey, the water's great, come on in. So I came out, checked it out, and here I am 10 years later. But Anchorage wasn't enough. And so about a year ago, I don't know how it happened, but I got in touch with the hospital here. I actually had privileges here, funny story. So to get privileges at the hospital, you have to come up and do an in-person interview. So the day I came up, I'm sitting in the lobby at Fairbanks Memorial, and I start getting all these texts on my phone. And they're like, hey, are you okay? I'm like, yeah, I'm okay. Another text, hey, are you okay? And I'm like, well, last time I checked, I'm okay. Then I realized, because I felt a little earthquake. There's a big one in Anchorage, and everybody thought I was in Anchorage, but I was actually here in Fairbanks with you guys. And so I finally figured out why they asked me was I okay, and fortunately my family and the house and everything were fine, so there are no issues there. But so I got my privileges and then did nothing with them. I didn't come to Fairbanks for a long time. But then fast forward, and then we get in touch, and we're say, hey, they're trying to redo the pain program here, and I said, I've got a little experience doing that. And by the way, I actually have privileges, so I can start tomorrow. And so we decided to both kick each other's tires, and here I am a year later. Time flies. I think it was April 29th I started last year. So I got through my first Fairbanks winter, and I didn't run away. So, all right, so he told you all the academic stuff, all that good stuff. So I've been about doing this for about 15 years since all my training. And my passion is fighting pain. I call myself the Mike Tyson of pain. I try to win, knock it out, but sometimes you fight Jake Paul, and it kind of comes back against you. Somebody caught that. Next slide, please. So what is interventional pain management? We're doing an intervention. Do we make them an offer they cannot refuse, right? So, well, generally, interventional pain management, we're doing a number of things. We're trying to figure out what is bothering you, why it's bothering you, and if there's anything we can do about it to make it bother you less, or if we're really lucky, to make it go away, right? So you go to the next slide. And so then we have to talk about what is pain. Something that hurts, right? That's the obvious, it hurts. But the definition of pain, and there's an organization that actually studies this called the International Association for the Study of Pain. And they'll tell you that it's a sensory and emotional experience. So it's not just you feel it, but it encodes itself somewhere in your brain, and it kind of creates a pathway. So it's not just that it hurt, you remember that it hurts through multiple pathways in your body. So when you see the hot stove, it's not just, oh, it's going to burn me. It's you remember how you felt when it burned you. And it's like, oh my goodness, this is terrible. Or when you broke your leg, or if you got chased by a bear or something like that. So lots of things that kind of encode themselves in your brain, and that can be protective. But it can also be a problem because it encodes itself in your brain and your spinal cord and in the pathways, so that once you have pain, sometimes it's easier to have the pain. So a lot of times what we look at doing is interventional pain is trying to interrupt those cycles so they don't create these chronic, easy express lanes to your brain of pain. One way I'll describe it is if you ever, I grew up in the South, and there's always some, old guy sitting on his front porch in a rocking chair, and if you walked across his grass, he'd say, get off my grass, right? Well, what's the big deal? Nothing's gonna happen. And if you walk across once, nothing really does happen. But if you do it every day, eventually you see some yards that have, a path through it, to the extent that no one actually has to walk on it anymore, but that path is still there. And that's kind of what happens with pain sometimes. When you have pain, and it should go away. We call that acute pain, a little bit of pain. And it goes away. And some people, though, it keeps coming back and keeps sticking around, and it creates these easy passes that go straight to your brain, and then it's just there. Your brain is just thinking about pain, feeling the pain all the time. And again, so our job is to interrupt that so that maybe the pain can go away, the grass can grow back, we can reseed it, fertilize it, water it a little bit, and hopefully have a nice green lawn full of normal grass again. So that guy looks like that probably hurts. Next slide, please. All right, so again, we talked about why do we feel pain? It's kind of like an early warning system that something bad may happen if I keep doing what I'm doing. So I'm probably going to take my hand off of this hot stove. I'm going to probably not be a little more careful when I'm hammering this nail, because when I hit my thumb the first time, that hurt. So again, we talked about the signals that travel up the brain, of the spine. I like to think like an interstate. It goes up the interstate, and we'll talk about it a little later with like some of the conditions, how certain things can affect things further away. So, for example, I was driving back to Fairbanks the other night, and I'd gone somewhere over the weekend, not in Anchorage. I wasn't even in the state. But I flew into Anchorage, I was driving back, and I didn't look at the traffic report. And everything's going fine. And then as I get about 45 minutes outside of Fairbanks, thinking I'm almost home, there's a line of cars. No brake lights, just line of cars turned off, people out walking around. I'm like, well, what's going on here? And so, just like that would have prevented me from getting here today, probably, certain things that are blocked in the body can prevent signals from going where they need to go. And you may feel things in places where the problem is not. So the fire was further down, but it would have felt the effects here. You may have a problem in your back and feel something further down your leg, and you see me and say, hey, well, I don't have back pain. And I was like, well, you don't have to, because the problem still can be in your back. All right, so the brain will decide from these signals whether it should do something about it, move your hand, reflexes and things like that. Some things you do quicker than you even know. You don't even have to think about it. Next slide, please. All right, so we talked about acute pain, and there's also chronic pain. So acute pain is just a little bit of pain. It's cute, right? Babies are cute, and it's here for a little bit of time, but then they grow up and become teenagers and things like that, right? And sometimes it's time to get them out of the house. They've kind of outlived their welcome. They're kind of expired. So acute pain is things that come in the short term to protective, and chronic pain are things that last months, years, and they often outlive their usefulness. And so they bother you when they shouldn't bother you. Maybe you had surgery, but you still have pain in the area. The disc herniation's gone, but it still hurts, or you've had some type of abdominal surgery, and this incision is still painful, and it's 6 months later. So those are the types of things that is not warning you about anything. It's not going to be a problem, really. And so we try to make those things go away. And so that's where we come in and try to interrupt those. And we'll talk about ways that we do that later. Next slide, please. All right. The emotional side of pain. We said it's an emotional and sensory experience. And so, I fly a lot. And I've seen some interesting things on planes. And, this would be interesting to see someone checking in with their own emotional support bar cart. But this is funny, but it's true. I have more than too many patients that come in and say, I drink because I have pain. It helps me with my pain, or it helps me fall asleep. And so that becomes one of the things that people rely on because sometimes it relaxes their emotions. There's a lot of overlap between the neurotransmitters in the body that are working in mental health conditions, depression, anxiety, and those things can modify pain themselves. And so you can find that pain will affect people's mood. They become cranky, right? Anybody here? Don't look at anybody. Anybody cranky? Anybody comes? No, don't point at anybody. All right. So it can affect the mood. It can affect your sleep. Some things hurt more at night. If anybody had a rotator cuff problem, you probably know that it would keep you up at night, especially at the beginning. Some things, when you try to get up in the morning, they give you problems getting up, or if you try to roll over in bed. So they can affect your ability to go to work, depending on what you do. If you do a very physical job, you may not be able to do that when you're having pain with those particular activities. Repetitive motions, a lot of kind of construction type situations cause these issues. Of course, social life. I hurt. Do I want to go to this thing tonight? No, I'm going to stay home, right? And then they're going to go to their emotional bar cart, and then they really don't want to go anywhere, right? So, and so that affects all these things. And then you start to getting something that's called catastrophizing. This is the worst pain ever. This is the worst thing that ever happened. I'm never going to be able to do anything. And if you pay attention, you realize that your mindset is very powerful. The way you think about things will truly influence how you can respond to things. They've done studies, even down to placebo and nocebo. Placebo is when you come in and say, oh, this is going to be great. You're going to feel amazing after this. And you're primed to feel amazing. If you come, oh, this is never going to work. This medication is no good. And guess what? If you take it, you probably won't do as well. And they've done studies where they tell people something is a sugar pill. You're going to feel better. They feel better. You're going to feel worse. They feel worse. And it's really a pill that should not do either one of those things unless you have a sugar issue. So anyway, catastrophizing is not a good thing. And so people that get into that mindset are also kind of laying the groundwork for their brain to kind of interact with that, right? So we said things that happen a lot. The more you think about hurting, the more you think about things are going to be terrible, the more they're going to hurt, the more terrible they're going to be. So you have to kind of work with mindset and pain. You have to work with expectations, and you kind of have to meet people where they are. You know, I have people that come in and say, I've had pain for 25 years. I had this injection in my back, and I've had this pain ever since. And I don't think I want you to give me an injection. I say, oh, well, I don't think I want to give you an injection. I was like, what? Why? I was like, because you already have it in your head, this injection, the last injection hurt you. You know, I can explain to you why it's probably not that case, or, you know, whatever you had going on that you had that injection for may be influencing why your back is still hurting. But if you already have it in your mind that it's not going to help, it's probably not going to help. And so I like to do risks and rewards, you know, and if our risks are too high, you know, rewards are too low, then there's no point in doing it. And so if you're not going to get better, and then we have some potential risks, and there are risks with procedures, then we're kind of tilting the tables towards those risks, which we don't really want to do. Okay, next slide. All right, so summary from those few slides there. Why does pain matter? Because it's an evolutionary benefit. It's meant to keep us out of harm, but sometimes it sticks around like a check engine light that you need to get around to getting checked, right? And if you don't, sometimes problems happen. Sometimes it's just stuck, and they just didn't reset it. They didn't change it if they did your oil change. So we like to investigate it because you never know until you ask, and so we kind of like to give the story. If anybody here has seen me, I kind of err on the side of listening to you, and so I will listen longer because I can get more information when you tell me what's wrong. If I'm a mechanic and you come and see me and say, oh yeah, I know how to fix your car, but I don't really hear the details of what's going on day to day. It might not be what I thought it was at first, right? And so I like to listen, and then in turn, I'd like you to listen back. And so I'll tell you what I have learned and thought, and I spent a lot of time studying this. And then sometimes people say, well, I saw this on Google the other night, and this is what I have, and this is what we should do. And sometimes it may be right. Sometimes you can't believe everything you see on the internet. Next slide, please. Okay, so now we're down to some common pain conditions. We've got a couple categories. Got pain in the neck. Got watch your back. We've got achy joints, like achy breaky heart. And then you've got some nerves. So most of the conditions that we see fall into one of these categories. There's something in your neck, something in your back, something in the joints, or something related to the nerves. There's some other things that outlie that, but most of them will fit cleanly into one of those categories. So let's get into some of them. We'll go to the next slide. All right, disc herniation. This is one that people have heard about a lot. And so essentially this is, if you think of the disc, it is a shock absorber that sits between the bones of your back, kind of a little cushion. So when you do things like, jump and dance and move and skydive or whatever you do, you don't come out broken. That's the goal of it. And the other factors that can play into that, maybe you have weak bones and you're likely to get a fracture if you do these things that shouldn't break you, but this gives you a little bit of springy cushionness between that. Now, these discs are kind of firmer, fibrous on the outside, that little blue area that you see, and then in the red area is more of a, we typically say a gelatinous type material. I've actually never done a discectomy where I remove it. And so I was talking to a neurosurgeon, and he said that it's more like, the consistency of like crab meat. If you get like a lump crab meat or king crab, it's good stuff. But it's kind of like that. It's more spongy, it's kind of springy. And so sometimes that can bulge out where it shouldn't be, poke its head in places. And then so the anatomy of the back, so at the top, this is the bone, and this is your back. You're laying face down right here. This is your back, the back side of your back. This is the front side. So the discs are here, and they alternate with the bones in your back. So there's a disc about that thick, then a bigger bone. This is not to scale. And then behind that, depending on where you are in the spine, is the spinal cord or nerves. And I'll say depending on where you are, because in the upper part of your back, or the majority of your back, down from the neck down to just below where the ribs end, that's where your spinal cord is. After that is just little nerves running by themselves in groups, but they're not connected to the spinal cord like that. So there's places that there's spinal cord behind the disc, and there's places where there's just nerves behind the disc. And then there's the corner pockets, I say, and then there's the nerve hole where it actually exits. And so you can get a disc herniation that can go directly backward and compress on things there. It can go off to the side and press on a particular nerve on one side or the other. And then that's where you can get symptoms that I only feel it on my left, or I only feel it on my right, or I feel it everywhere. So like we said before, with the highway and getting stuck affecting things further down, if I am in the neck and I squeeze things, the spinal cord's there, and if it squeezes tightly enough, it can affect things that are way beyond the neck. Typically, just like the back, you think about sciatica, things bother people in the low back and it shoots down their leg. The neck is a similar issue where if it bothers the nerves there, it can shoot down the arms. Between the neck and the low back, it mainly can just wrap around with the ribs, but it's a fairly uncommon place to get disc herniations. It can happen, but it's not common. So mostly people will come in complaining of an issue that is in their back and or shoots down the leg, or in their neck and or shoots down the arms. Occasionally they'll come in, if it's really bad, it'll be something that they feel everywhere. And again, that's possible, but not the most common presentation. So again, what you usually feel is some kind of sharp sensation, burning, numbness, tingling, that goes and follows nerves. I didn't put a picture up there, but there's a map of where you typically feel things based on which nerve is being irritated. So we call that a dermatome map. So derm like skin, dermatome. And it's not perfect. Everybody's a little bit different. So you'll see it. If you came in the office, I'd show it to you and say, well, most L4 is going to run, go out the side and go across the knee and down to the inside. And you say, well, mine does something slightly different. And that may be the case, because nobody's the exact same cookie cutter body, but they're very similar. So herniated discs can go out. They can come back in. There's a study called a sport trial, big study, and they look at people that have surgery and don't have surgery, and they say that you end up at about the same place in 2 years. It can be a miserable 2 years. And again, that's kind of where sometimes we come in, where if it's just pain, we can probably make it go away sometimes, but sometimes it's squeezing on things, and the nerves, some of them in the body have more than one function. They not only carry sensory information, but they also carry strength, motor information. So they tell your muscles to work. If those are being compressed enough, it's not just that your leg feels numb and tingly, it doesn't hold you up. And if those things happen, especially if they happen soon, over a short period of time, then you really need to get in and see the surgeon to have them open up that area. And that's a whole different lecture about the different surgical approaches that they can have. But they'd open that up to give you more space if needed. There's other surgical emergencies and things like that. If you suddenly can't hold urine and bowel movements that you could do before, uncontrolled pain or things that seem like there might be infection. So long and short of it, go see somebody and let them help you figure it out. Don't look it up on Google, okay? All right, so next. All right, so this is kind of goes right into spinal stenosis. I was just telling you about a little bit, the squeezing that can affect things down the road, right? So spinal stenosis, before it was just the disc that was bulging out. And there's other structures in the back, and they can all play a role in this. So there's the disc, it flips you around. So now this is your back, and this is your front. So this is the bone that comes into the back. This yellow thing here is a ligament. Fancy word called the ligamentum flavum. Anybody spell that? No? No? Okay. All right, so it thickens as we age, and it runs from the base of your skull all the way down to your tailbone. This is kind of what happens when somebody has an epidural here, someone going to have an epidural for a baby or for surgery. You kind of go in through the spaces between the bones, and you get into the ligament, and once you get just past it, that's where you can put the medication. So if you're having a baby, you don't need a steroid, you just need local anesthetic, so it's not hurting so much. And that's kind of where my field came from, honestly. They're anesthesiologists, and in between cases, and they said, hey, you think you can put some steroid in there? And they kind of came out and started putting steroid in there. So interventional pain management originally came from anesthesiology, doing steroid injections in the epidural space between cases. Kind of caught on. People say, hey, I feel better with this. And it kind of developed its own specialty. And with anything that's good, you get counterfeits and copycats, right? So there's other specialties that try to do pain management now. But, I'd go to someone that's been handling a needle the whole time. So anesthesiologist. I won't let anybody else do an injection on me. They actually have psychiatrists that can do a fellowship to do pain management. It's important, but I don't know about the interventional side. I'd talk to them, but that's about it. Okay, so this ligament can thicken, and so it can press on things from the back going towards the front. From the front, we already talked about the disc. You can see this one kind of bulging back, pressing on things from the front going towards the back. There are bones in the back, so the bone, it sits on each other kind of like that, right? And so there's kind of a little connection there, and if these bones get larger, they also can protrude into the canal. Where you see them, the other one kind of sit on top of that, and they're kind of a circumferential joint. And so when they get larger in a circumferential manner, and so they start to protrude into the canal. Just like any other arthritis, rheumatoid arthritis, you see it, the joints get larger. More weight-bearing stuff, knees, things like that. If you look at a knee, if somebody's had the knee replacement, it usually widens out because it distributes the force. And so if I pushed on your leg really hard with one finger, it might hurt. Same force using my fist, I'd have to push a lot harder for it to hurt. So the body's smart. It's trying to widen itself out to distribute the load. And so that's what happens there. Those bones get bigger, ligament can get bigger, and the disc can get bigger. Any of those things can cause narrowing of either the spinal cord or the nerves, and that's what we call spinal stenosis. It just means a narrowing or tightening around something. Now we told you have going down the canal from the neck Going down, that's called the central canal. Now, coming out, these are the foramen or foraminal. So you can get foraminal stenosis or nerve hole stenosis is what I call it to most people. I don't like to use big words too much because people don't know that and they have to go home and look it up. I want you to understand what I said to you when you go home. So I use words people understand. So there's nerve hole stenosis and then there's kind of main highway stenosis. So the exits can be affected or the interstate can be affected. And there are different ways to intervene with things like that. And we'll talk about some of that more later. But spinal stenosis typically, because of that narrowing, people feel better sometimes if they lean forward. It opens up the spine some. So you often find that people, sometimes as they age, they will start to kind of walk a little bit more bent over. And then you find that a lot of them really enjoy shopping carts because the pain doesn't bother them as much with shopping carts. They actually created a sign called the shopping cart sign saying, hey, if you go to Costco, can you walk further if you have a shopping cart than if you don't? And if the answer is yes, they might have spinal stenosis, right? And so it's one of those things that you, again, you need to listen to what you say, kind of the things that affect you, and you can find out what's going on. It can give you back pain. It can give you leg pain. It can give you both. It can give you just numbness and tingling in an area. It can give you weird things because, again, central stenosis can affect anything. So anything going past wherever it's narrowed at, you can feel it. So it can be in your neck. You can feel it in your legs. You can have weakness in your legs. It can be in your low back. You can feel it only in one leg, or I feel it going down to my big toe. And again, the nerve map, which I wish I had put it in here now, but the nerve map would show you where you feel these typical things. And so a lot of times we'll seem like we're just being annoying. It's like, so where exactly does it hurt? I just typically say, hey, can you stand up? Show me one finger where you feel, trace it out, and that'll help me. Because otherwise people's words get very creative. They start telling these stories and say, what do you hurt? Well, when I was 17, I went to, so that stuff. So we get past that. We just say, hey, stand up for me real quick. Show me where it hurts. Show me where you feel it. So you feel better when they're leaning forward. They have the shopping cart posture. And, that gives it more space. It kind of takes some of the pressure off the disc, takes some of the pressure off the bones, and creates more space for those nerves. And so people feel better with that. All right, next condition. Same one here. So another picture of the same. So this is kind of give you kind of a cross-section view. We're looking down again. This is your back because you see the pointy Y, which is called the spinous processes there. And so then this is one where things are kind of normal. And I told you about 3 things that can narrow the spinal cord, right? Narrow the canal. That ligament, which now you can see it better, thickened, is red here. So that's coming from the back. Pushing that same picture that you see here, pushing it forward, right? And then you have the disc that's bulging from the top, and that's pushing that towards the back. And then you have these bones that have gotten larger, they're pushing things further in. So spinal stenosis a lot of times is a combination of 3 things. And again, depending on which one or which ones you have, there's stuff that we can do about it. Try to calm it down, because what happens to the nerves is when something's pressing on them and irritating them, it's just like if I came and just started poking you. If I kept poking you, eventually you're going to get mad at me. Hey, what are you doing? But you're going to get bigger. You're going to get, and then when you calm down, you go back to your normal self. So that's the same with the nerves. They get upset, they get bigger, they swell. And so a lot of things that we do look at trying to prevent that process or stop that process. All right. So next slide. Sacroiliac joint pain. So a lot of things that can cause pain. And the kind of knee-jerk reaction when someone says they have pain, they show up at the ER, is like, oh, we're going to get something X-ray of your back. We're going to get an MRI of your back, and it's usually the lumbar spine. Lumbar spine is everything between the ribs for the most part and kind of where the sacrum starts, which is this. So if they do a picture of this to below the ribs, you miss this, right? And so it's your back. And again, it's important to know kind of what you feel, what bothers you, because this may have a slightly different presentation. And then I can also differentiate it when I say, hey, stand up and point with one finger where you feel most of the pain. So if you point down here instead of up here, then it's going to say, wait, we should probably do something different. So SI joint, sacroiliac joint. There's the sacrum, which is the bottom part of your spine, this kind of triangular thing here. And then there's the iliac crest, which go out to the side. When people say they put their hands on their hips, they're putting it out there, not really your hips, but we go with it. And say, all right, show me with your finger where it hurts on your hip. So we always try to educate, but we don't, waste as much time as we don't need to. So anyway, it's where that meets together. And so those joints, if you imagine, well, I'll tell you what people typically have when they present with this. Pain with transitions is the most common thing I hear. I'm okay until I try to get up. I can sit until I try to get up, or I'm fine standing, but when I try to sit down, if it's a low chair, if I'm sitting for a long time, or if I'm laying down in bed, when I get up in the morning, it's really hard. And another thing is when I'm putting my socks on. Because you got to imagine all these activities, if you think of this joint, is connected, but they're not really connected. It's connective tissue holding them together, but they're not one solid block of bone. So things can happen that make this joint loosen, and then they can become wiggly and wobbly, and then certain activities can aggravate that. Other things, leg length discrepancy. Some people have one leg that's slightly longer than the other, or they had some type of surgery. They had like a knee replacement or hip replacement and didn't quite get exactly back as you were from the factory, right? So maybe there's a little bit, you don't notice it. It's like eventually you walk long enough and it's sending forces, because now you kind of rotate it, sending forces through there in ways they weren't always there. So that pain can come up. Other times people may have a spinal fusion or surgery up there that connects that part of your back to this part so things don't move like they should, and it puts more force on these. One of the things with the transitions, when you sit, this bottom part is the part that actually touches the chair. These usually don't. So when you get up, this is kind of fixed in place, and those are free to move. So that's what transitions give people a lot of pain when they're getting out of chairs, getting into cars and things like that. Other things, kind of pivoting, moving, and bending, especially compound movements. You should always face the task. If I got to move something, you should walk up to it, and then you turn, as opposed to grabbing and going like that. And that's going to shift, and it's going to cause pain, sooner or later. The other thing that predisposes people to this, there's some autoimmune stuff, which we won't get into that, but their pregnancy. People that have had a lot of babies, one of the things the body does to prepare itself to have a baby is it loosens the ligaments in the pelvis, right? This is one of them. They don't always tighten back up the way they should. And so then you compound that with a couple falls. Falls are bad. Falls in the ice. I fell and landed right on my back. That knocks it loose a lot of times. So that can give you this pain in this area. Again, transitions, getting in and out of chairs and out of cars, out of bed in the morning can be an issue. And next. This is an injection. Somebody came in to get an injection. I said, if you're fused in your back and it comes down and connects to that part of your back, and that's what these are. These are like the fusion screws and rods that come down. So you're connecting the regular lumbar spine down to the sacrum. So now things don't move like they should. And this person had an SI joint pain. So we did an injection where we come in under x-ray guidance. Most of our injections we do under x-ray guidance or imaging guidance. And we bring in the needle. This is my needle kind of coming in from an angle. This is the tip of it. And I've injected contrast in the needle to spread. And you can see it coming there and following the joint. And so that's kind of what we will do to address that. And we'll talk a little bit more about a different injection. So in case y'all couldn't see it over there, needle coming in and kind of going up the joint because it kind of goes on an angle as you saw a while ago. So that's under x-ray guidance. That's the typical thing we see. Next slide, please. Right. And then we have nerve pain. You got me getting on my nerves, right? Neuropathic pain, burning, tingling, numbness. There's neuropathy, peripheral neuropathy, which is typically in what we call a glove and stocking pattern. So if you put on some gloves and you put on some stocking or hose or whatever people wear these days, that's typically where you'd feel it. They feel it coming from the bottom, coming up. Oh, my fingers were tingling in my hands. And this is associated with certain conditions, some like diabetes. Shingles is more of a dermatome pain, meaning it follows specific nerves. So I probably shouldn't have put that on the slide, but it can cause neuropathic pain, just not in a glove and stocking distribution. Chemotherapy. Certain chemotherapy agents can affect the nerves, cisplat and some others, and you can get burning, numbness, tingling. You look at an MRI, everything looks fine. You check a lot of things, and everything looks fine, but it's from the chemotherapy agent that it's doing it. Certain surgery can give you neuropathic pain, so I'm kind of jumping between peripheral neuropathy, which is usually glove and stocking, and just other types of neuropathic pain. Surgery can do it, infections, a number of different things. And so, again, it's going to be burning, numbness, tingling, and it's something that people don't like. And there's a lot of things we can look at doing for it, whether there's medications, there's like light, kind of an electrical stimulation type therapies that aren't usually offered too much. They're not usually covered by insurance, but they can work. A lot of different things that can be done for it, even though often people will say, oh, if this gabapentin and pregabalin don't work, oh, it's just going to live with it. So always come and talk to somebody who thinks about pain a lot, and we can say, hey, I might not do it, but we might know some other resource that someone else didn't think of. Next slide, please. So what do? We're medical detectives. We've got to figure out what it is, what's bothering you, how it's, what's triggering it, what's keeping it around, and kind of how to make it go away if we can. There's some things that should have popped in, but I don't know if you have to tap the space bar. They probably, look, listen, and feel. Should be one. There it is. A little delayed. All right, so we look at you, we examine you, we listen to your story, what you have to say, and then, again, the feel is like, we check certain things. Maybe we check your reflexes, maybe we check your sensation, and we kind of try to map it out, because maybe if I check your sensation around your leg, you don't feel it on the side, and it kind of follows that certain nerve root, and it's like, oh, well, you may have a problem with the L4 nerve root. Let's get an MRI, see if something's pressing on it, right? Then you get into the insurance administrative things of, oh, well, they haven't done 6 weeks of physical therapy and you're hurting. And so I get it because I'm sitting there staring at you and you're like, I'm hurting. What do you mean I got to do 6 weeks of physical therapy? It's going to take a week or two to get in. And, you know, I understand. So trust me, I understand, but they make us do what they make us do sometimes. Next slide. All right, so categories of things that we can do of interventions, right? So one is steroid injections. Everybody's heard of that. I call it the roid rage whisperers. It calms down the rage, you know. And so usually there's some type of inflammation in the body. And anybody that sees me, I usually describe a lot of inflammation, kind of like these forest fires that are bugging us. They kind of is burning, something kind of burning, upset. You know, we want to calm it down, and so I become the firefighter, right? And so we're trying to calm it down, put things out, and get it to the point where the body can handle it. So I'm not dumping water on it. I'm putting a steroid, which is a very strong anti-inflammatory, just like ibuprofen, Advil, those types of medications. So instead of taking a pill and taking some water and getting it in your bloodstream and going all over, we're actually concentrating it, putting it in a needle, and trying to inject it at the place that's going to be most likely to give you the relief. So putting all the anti-inflammatory or all the water on the house that's burning and not just raining on the neighborhood, right? So that's what the steroid injections, you probably heard that. We're not going to spend much time on that. Thermal ablation, we'll talk some about that. So that's like radio frequency ablation. Can also be some cooled techniques called cryotherapy, but typically what we mostly do is what's called radio frequency, where you heat up a certain area and you're actually causing damage to a nerve and you make that nerve stop working. In some cases, that nerve starts working again later. In other cases, it doesn't. This is used in different fields, not just pain. I don't know if Dr. Wren will talk about it. I think he's speaking in a few weeks, but cardiology, they use it. Sometimes people have rhythms. You know, the nerves are kind of stimulating in an uncoordinated pattern, and they want to shape that so they can stop certain nerves from doing that and make the heart contract the way it should. So in this case, there are nerves that are doing their normal job, but their job is to tell you that you have a pain that you should not have, not because there's a problem, but because it just likes to tell you things that you already know, right? You got a friend like that? Say, hey, you already know this. Right? So you want to stop those nerves from just saying, hey, you know what? Hey, you remember you got arthritis. Hey, did you remember you have arthritis? And you just stop it. And so it goes in, and we first prove that we can stop it by injecting local anesthetic, just like you get at the dentist, temporary little test, and it wears off later. So you come in and we identify which nerves, are going to that area, whether it's the back, and there's some newer things for hips and shoulders and things like that. And we can put some local anesthetic on it, and we see what happens to your pain. If it decreases significantly, and usually I don't make these rules, but significantly means like 75%, 80% or more. Most people are happy. If your pain cuts in half, 50%, most people would be happy with that. But the bar is pretty high for this. So one of the things that's, a little frustrating is that you have to, even if that might be 60% of your pain, you got to get rid of the other things first. So you might come in and say, I think it's your arthritis is causing most of this, but I think there's a disc that's causing 30% of your pain. So if it's causing 30%, you'll never reach the threshold. You need to proceed with the radio frequency. So we'll say we need to treat this first. You may feel some better, but I think when we do this later, you're going to feel a lot better. So that's where you get into the insurance companies dictating what you can do for people, which is not always in your best interest, but they pay the bill, so that helps, right? So we listen to them. So the ablation, after you've proven it, you do a test injection, you usually do a second one if they get 75, 80% reduction for the duration of that local anesthetic. And there's different ones, they last different amounts of times. I usually like to use one that will work pretty quickly so we can get an answer almost before you leave the office. You say, oh, I feel my pain was a 6 and now it's a 1, or my pain was a 6 and now it's a 0. And so we use that local anesthetic to prove that we can get that result that we need. If we get that twice, we go to radio frequency, where we put the needle in a very similar place, but instead of just injecting it widely what a local anesthetic does, we have to get pretty precisely on that nerve. And sometimes it's in a high real estate area, meaning there's other nerves in the vicinity, and we don't want any innocent bystanders because we're going to stop the nerves from working, right? But if you need your leg to work, you want your leg to work. So we do a test once we get in there. So we've done 2 tests to prove that it works. Now we're going to do a test to make sure we're not going to affect the nerve we don't want to affect. So we stimulate that nerve, and it can cause muscle movements and things like that. If we're too far or too close to the nerves we want to, we don't want to be near, and we can adjust it before we knock out the things in that vicinity. So some places do that under anesthesia. They knock you out. I like you to be awake so you can tell me what you feel and things like that. So I'll give you a lot of local anesthetic. I've been pretty much the whole time for 15 years since I've been doing pain management. We've not done much with sedation, so I'm used to people being awake. So I'm know how to do it generally without you having tons of pain. Not saying that everything is going to be painless, but it's not something where it has to hurt. Matter of fact, I was criticized for that in one of my reviews in one of my first jobs. They said, if it's not hurting, you're not doing it right. I was like, no, you can just it takes a minute longer, but we give some more local anesthetic. It's okay, we'll be nice. I picture myself on the table, right? And so I try to do things, and the same thing, if I recommend something, is like, yeah, I wouldn't recommend it to you if I don't think I would recommend it to myself or a family member, right? So that's kind of my code. All right, so thermal ablation, we'll talk a little bit more about that later. So neuromodulation, there's devices, there's implants, things that go in your body, may stay in your body, and they can reduce the pain. They're usually not a first step because nobody wants to become the bionic man, maybe you do. But you usually do some things before you get to that point, and it's like, look, we're getting results with this, we're getting results with that, but it's not lasting. We can't keep coming here. Steroids can have side effects if you use them too long. So let's look at something else that might give you more lasting relief. That's that category. We'll get into it a little later as well. And I think I've got till 8, sorry, about 15 more minutes.
Right, in a few minutes for
Okay,
questions.
after 8,
You
okay.
got it.
All right. So vertebral augmentation, that's when you're broken inside, right? And so that's for lumbar compression fractures. And so some people have weak bones, and the vertebral bodies, the bones in your back, are soft, and something that we'll call it a low velocity injury, meaning it shouldn't hurt you, but it hurts you. You broke some bones, but it's not like breaking your arm where it cracks. It usually smushes, right? And sometimes it smushes like a wedge or something like that. And so vertebral augmentation is you can go into the bone, we'll say with a tool, kind of like a straw. Put in the straw with the insert, you take out the insert, and you can fill that bone first with a balloon, and you kind of try to inflate it back up. And then if you take that out, it's going to go back down. So then you backfill it with some bone cement, same type of stuff they use to put in joints replacements and things like that. And so then that kind of helps it keep its strength, and it hardens pretty quickly. So if you had this type of issue, it usually feels better. You have some certain procedural discomfort, but it usually feels a lot better when you leave because that fracture is now casted from within, right? And it's going to stay hard and not break. And you want to strengthen your other bones though, because now you have a reinforced bone that may put more pressure on your other bones. So you want to make sure you've gotten the medications. If there's endocrinology involved, talk to the endocrinologist to make sure that he's giving you something to strengthen the other bones so they don't do the same thing. Next slide, please. So steroid injections, this epidural steroid, we talked about a little bit about that. I won't spend much time here. Again, we told you how steroids work. Very strong anti-inflammatories. You're putting it where the problem is, trying to calm down irritation, put out the fire. We're coming into the bone, between the bones, till we get in that space just behind things. And this is kind of like a little feeder trough where the nerves get their nutrition and get all this stuff from it. So you put some medication in there. If it's a local anesthetic, it can affect the nerves. You put a steroid, it can affect the nerves. So if they're upset and inflamed, they calm down, they shrink, they have more space until they get upset again. And so one of the questions people ask, if I get this injection, how long is it going to last? And I say, I don't know. Because everybody's different. We're handing a baton to your body, and then we're going to see what it's going to do with it, right? And so for some people, they get one injection, and they're good. I call them one and done. They don't need to come back. They don't have anything else for another 10 years. And they say, well, I want the same injection I had last time. It lasted 10 years. It's like, well, it didn't last 10 years. It lasted 6 weeks. It's usually gone in about 6 weeks, but your body could handle it at that point. The other point to point out is things that happen slowly, your body can usually deal with it. So if you've got spinal stenosis and you don't find out till you're like 80, we can probably calm that down, and you probably should do pretty good with it because it probably happened over 80 years. If you're 27, you have this big disc herniation that suddenly appears there, that's going to be very painful, and you're going to be hating life for quite a while until they get it calmed down or get the right medication or injection done. So this goes in, again, if the problem is a disc herniation or spinal stenosis, whatever it is, it's rubbing and irritating, we're going to put the anti-inflammatory and calm it down. So relieve the pain, usually shooting down the arm, shooting down the legs, and those types of things. Next slide, please. We talked about radio frequency ablation. And so again, we're trying to turn off these little sensory nerves. They're doing their job. So there's nothing wrong with the nerves. They're not bad nerves. They're good nerves, but nobody likes a snitch. They're like, hey, you got pain. So snitches get stitches, right? So we turn them off and make them stop working, but they grow back. And the way we turn them off is with the heat. So the heat essentially melts the lining, which is kind of an insulator around the nerve, just like electrical wire. If you strip the electrical wire, it loses its signal as it travels and it doesn't work as efficiently. So same thing here, but it grows back over time. So for most people, usually about 6 months, 9 months, that nerve grows back and repairs itself and the pain comes back. And so at that point, we've already proven it that we can make it go away. We don't have to do those tests again. We can just go right back to the radio frequency and make sure, we do everything the same in the same places, and you should get a similar response. There's a theoretical, if you do it too many times, the nerves will, create little superhighways that go around and, bypasses, and I'm not really seeing that happen. So, and theoretically it could. If it does, we have other treatments for it. So if little brother doesn't work, we call big brother. But this is it. So things we can do with that. Backs are most common. Necks, right behind that. More recently with some devices and things that we can do at a hospital that you can't necessarily do in the community are joints like knees, hips, and shoulders. And so we just got a new radio frequency machine over at Fairbanks Hospital, FHP, that can do those, right? It's called cooled radio frequency, and so you can get to those hard to get places where, you went and they told you need a hip replacement, but you're not a good candidate medically, or they said, you need to go do this, stop, whatever it is you need to do to get it fixed, and you can't do that. Or they say, go lose weight and you hurt, you can't go walk and do things because it hurts to walk. This can buy you that time where it's not so painful, and you can do those things to get that treatment if you desire it, right? So it opens up doors for things, and that's what I like about most of the interventional things we do now. It gives people options that may not have had options before. The only options are sit home and suffer, or back when pill mills were popular, they get, hey, go get a pill, and say, just take more pills. And so we don't like doing that because you're covering up the problem, and people are getting worse with that, and they're actually creating other problems from those medications. Next slide, please. All right, so this is another kind of iteration of radio frequency. A lot of the things, and you may see in other areas too, a lot of things in medicine are evolving to be energy, vibration, frequency based. Matter of fact, I saw a thing the other day I forget the name, but it was a device that Medtronic wanted it, GE wanted it, and Johnson & Johnson wanted it, and they're all looking to pay about $2 billion. It can ablate a tumor from outside the body without even an incision. So frequencies, energies, again, another application of this frequency, energy, heat, inside the bone. So sometimes you get an MRI and say, your discs look okay, there's nothing pressed on anything, your joints look okay, but you have this pain, and you look a little closer, it's like, wait, at the bottom of your bone there, you have, that's a fancy word, we call it modic changes, which basically means edema inside the bone. It's represented by this redness here at the bottom. And so if you punch the wall, your hand's gonna swell. If you irritate your bone in the back, the bone can't really swell, so it accumulates fluid inside. So you get an MRI, what it's doing is kind of changing different, views, and you can see fluid here and that, and it looks a certain way. So if you have fluid accumulating at those end plates, the bottom of the bone vertebrae, or the top, then it tells us, you'd probably be a good candidate for this particular procedure. It's one of the few procedures that doesn't really have a test to do beforehand, but it is it's a little more invasive. It's more invasive than an epidural. You come again with similar straw. So like we said, if you had a fracture in your back, you put a straw, you put cement. This has a similar straw that comes in and it seats right there in the middle of the bone, and these little nerves that are kind of spreading out from there, it heats those up. And this one, they don't really grow back. So when they have this procedure, the pain may get better and stay better for quite a while. Like, I don't think you usually repeat it. So that's kind of newer to the market. We're pretty close to having this at Fairbanks right now. So I think we got it approved by hospital, approved by credentials, approved by the operating room. And so you may see some information about it soon if you have these types of issues. These people will say, my pain, it's the same all the time. It's always there, never really goes away. Nothing I do makes it better, nothing I do makes it worse, because it's not really pressing on anything. It's coming from within, right? And so this is something that can help those types of pains. Or even if they have other things and you tried it and this didn't work and that didn't work, it's like, you do have these modic changes. This may be something that salvages that picture and gives you another option. So next slide, please. All right, so this is mild procedure, minimally invasive lumbar decompression. So essentially a baby surgery, right? So if you have something pressing on your spine, usually for spinal stenosis, talked about a number of things that are squeezing in there, right? So they can go in and they can instantly relieve that surgically. They can just cut off the back of the bone. They call that a laminectomy. And that instantly gives you more room because there's nothing, that's pressing on the bone there. But again, maybe you have medical issues and you can't go under a big surgery to have the bone cut off, or you can't recover from that. So this, for specific cases, this can be helpful. And this is, we said 3 things that narrow the spinal canal: the ligament thickening, the disc bulging backward from front to back, and then the bones getting bigger. This addresses primarily the ligament thickening because it's from the back side. So from the back side, this is your back, now this is your front. And the ligament thickens, this little green shows the ligament bulging forward. And you don't have to move it a lot, but if you create a little bit more space, it moves it back there. It gives those nerves more space to get by. So you kind of go into essentially like an ice cream scoop, and you scoop out some of the ligament. And we did it under imaging guidance. And it rewinds the clock a little bit. It's not going to fix you like the big surgery will, but it also doesn't have this, side effects and the big recovery like the surgery will. We do it through a little small hole about the size of a baby aspirin, about a 30, 45, we'll say an hour by the time you get in and out of the OR. No general anesthesia, just under some sedation. Once we had someone that, I guess I don't know what he did at home, but the sedation didn't really work on him. And he didn't tell us that. And so we're there doing everything, and we say something, and he just answers like he's wide awake. He's like, "Hey, you okay?" He's like, "Oh yeah, that's fine. I'm just listening to you." It's not a painful procedure. Again, it's like a pretty big straw, like a milkshake straw. But I probably have less people complain of back pain after that than after having just an epidural, which is really interesting because it's really, really tiny. But it doesn't cause much pain, and people usually feel better pretty quickly. Sometimes you have a lot of different levels, and you want to figure out which one is causing it. You try to do maybe more than one. But it's something where it doesn't burn any bridges. If it helps, wonderful. If it doesn't, you can still go have the big surgery if that's what you have your heart set on, right? But the goal is to make it so we can do things to make you feel better without you having to do that if you don't want to, or most people here may have Medicare. Medicare reduced the number of injections. You can get epidurals from 6, which most people would do, down to 4. So maybe you're getting by with 5 injections a year, and now you can only get 4. This rewinds the clock to maybe, where maybe 3 will get you through the year. Maybe you don't need any or very few. So it gives people options without having to have the big surgery, right? So I like that one. And it gives people, the next slide I think talks about what people generally have from the studies. You can go to the next one. Yeah, so about an hour, like I said, under light sedation. Standing, people say they can stand. It went from 8 minutes to 56 minutes. This is in a big study. Walking 246 feet to almost a mile, right? And so it's a good in terms of what you're looking for, and it's for people that have lumbar spinal stenosis, fancy word with neurogenic claudication, just means your leg hurts when you walk. If you only have back pain, it's probably not for you, but you have to have the leg pain with it. Very few complications, no general anesthesia or stitches. Go home same day. You can kind of generally do your normal stuff the next day because we didn't really do much to you other than create a little bit more space. So great procedure to consider. Just remember it's called mild if you want to look it up. Next slide, please. All right, spinal cord stimulation. This is, again, we talked earlier, you've had surgery, they removed the disc herniation, they opened up the spinal stenosis, but you still have pain shooting down your leg. Or you've had something terrible like post-herpetic neuralgia from shingles, where you had shingles and it kind of went away, but the pain didn't leave. And you have these pains that are nerve pains, by definition. You can do this stimulation device, which is invasive. It goes in your body, stays in your body, and it can make the pain go away. It used to be that it replaced the signal that you had, or the pain symptom that you had, whatever you felt was something that you hopefully felt better or liked more. Now it's to the point where it just kind of makes the pain just disappear, like with the force, like the pain is gone. And so it takes a couple of days to do that. But what I really like about it is that you get to try it before you buy it. So it's a temporary trial. You come into the office, we put it in through a needle, and we leave in these 2 strings about the size of maybe some spaghetti, right? A little smaller than that. We leave those in, you go on with it for about a week, and you get to see what it does for you before you have to commit to having the permanent one put in. Because the permanent one has a little battery pack, just like a pacemaker. It's originally made by the same companies that made pacemakers. So for the permanent, there's a battery pack that gets implanted in your lower back, kind of right about in there. And for the temporary trial, we just stick it with a special pouch to your back, and you go on with that kind of sticking from the back into there for a few days. Because it's going from inside your body to the outside, we can't leave it for more than like a week. So we're going to take it out regardless. If you liked it, if you loved it, if you felt great, it's coming out. But if you loved it, then we can get you set up for a permanent one. And you really have to love it. I tell people, put all feelings aside. Don't say it felt good to make me feel good. Just say, hey, I loved it. I can't imagine life without it. Or, it's okay. And if it's just okay, you shouldn't get it because, it'll not be better later, but I don't tend to talk people into things. I tell them the information and kind of tell them what it may or may not do and let them make their decisions. And so that's kind of where we're at with this. But again, I like it because you get to make your own decision. As I say, you don't have to take my word for it. You can go home. So same thing I say also, don't take anyone else's word. If someone says, oh, my cousin-in-law's nephew's sister's wife had a stimulator and it didn't work well. I was like, so, you get to try and see what it does for you specifically, right? So that's what It's good, it's neat, and it helps a lot of people that otherwise would have to just deal with that nerve pain. And it's expanded its indications. When it first came out, is for post-surgical pain. You had disc herniation, they did a surgery and the pain is there. Now peripheral diabetic neuropathy, even just chronic low back pain with no surgical solutions available is covered for this for some insurance companies. All right. I think we're getting close to the end. Next slide, please. All right, one more, I think this is it. Kyphoplasty, we talked about the compression fractures, right? So the bone smushes like this one in the middle, right? And again, maybe you jumped, fell, whatever it is, and the bone was too weak or just something really bad. I had a young guy once who was in a plane crash, fell out of the sky. And he came in and he had a compression fracture and bone was smushed down, and you can pump it back up with the balloon. You put it in cement, fill it up, and then voila. It'll never be like brand new. They always make the pictures look like it's factory perfect, but it'll be better than it was. And things we worry about with that, if it's smushed and fractured and going that way into the spinal canal, we don't want to put anything in here because that can permanently press on the nerves and things like that. So we want to make sure the back wall of that is intact and there's no contraindications. And so it's not for everybody, even if you have the conditions that typically would be used to treat. We have to make sure we do it and do it safely. All right, next slide. All right, so we're at the end here. What are the key takeaways? There's pain. It mixes, emotions, and it mixes sensory. So it's a mix of the mind and the body, which, again, we didn't talk about medications tonight, but there's a lot of medications that can be used, whether they're antidepressants, and people say, well, I'm not depressed, why are you giving me this? It can still help. There's certain medications, Cymbalta, duloxetine, helps nerve pain, helps depression. Newer ones that are still not quite understood or mainstream, low-dose naltrexone, no one really knows exactly how it works, but it can help a number of things that are totally unrelated. So again, there's a connection with the mind, the body, meditation, all that stuff, because as your mind concentrates on certain things, it affects things. So I tell people, tell yourself, I'm going to feel great. Don't say, I can never do this. Say, I'm going to do this. I'm going to do this again. I'm going to feel great. I'm going to do whatever I need to do to get better. So if you come in and say, there's nothing you can do for me. I'm like, yeah, probably not. So, all right, but we have safe ways to target different pain conditions and, try to help you get back to the things you love to do, whether that's family, work, friends, gardening, traveling, fishing, hunting, whatever that is. Usually say stop carrying the heavy moose quarters after some point because that really is not good for you. So, but you're not alone. Help is here. We're not the government, but we're here to help. Okay? Next slide. I think that is it. There's a QR code if anybody's savvy. I'm in the process of making little videos, short videos, like a minute, about different conditions. I've got about 4 or 5 of them up there, but I'll be adding more to that QR code, epidurals, things like that, kind of like just what you need to know. And then we're almost right on time. We can turn it over for questions.
Let me just jump in. Normally we pass this microphone because it's cumbersome in the time, and I'm sure there are questions. Could you just repeat what the question is, and
Sure.
It's picked up on the audio and recording.
Absolutely.
So with that, hands for questions. Dr. Gale will pick you on.
You talked about a lot about the neurological. So what about pain management for cancer and other catastrophe diseases?
Sure. And those kind of come down to the same thing. So cancer treatments, whether it's radiation. I'm sorry, the question. All right, so I don't follow directions very well. So you said, what about treatments for like cancer pain, right? And so cancer kind of follows the script in terms of it affects some of the same things that we talked about before. A lot of times it may be the nerves, but it's also this soft tissue pain. So if you have radiation, depending on what type of radiation they do, it may destroy the cancer deep within you, but it may destroy some things on the way in as well. Sometimes those are just sensory nerves. They might upset those and you have pain from the nerves. Again, we talk about the chemotherapy agents, and those commonly can do that as well. So it kind of depends on what you had. Again, it kind of comes down to listening. What did you have? What are you feeling? And figuring if there's something we can intervene with, right? So if it's a issue where the nerves have been affected, by medication or by radiation, or even by surgery, they go in and they remove the cancer, but there's some sensory nerves in your skin, and you can't see them, they can't avoid them, so it's not the surgeon's fault. But sometimes these sensory nerves get upset, or you suture things back together, it might get cinched in a suture, and you get what we call a incision, like a neuroma, which is a little small nerve, knot of scar tissue around it, and it hurts. And so there's things we can do, but it's kind of an individual basis for those. But the one thing I didn't talk about, implantable devices, if all else fails, and like say sometimes cancer is terminal, right? And say, I'm not going to get better. medication is important, but sometimes the pain medications have a lot of side effects, right? So, if it's terminal and you're going to be end of life, you want to enjoy that. You want to talk to your family. You don't want to be out snowed and out, So there's an implantable pain pump that gives you pain medication, same into the epidural, deep into the spine. And so it's not going through your body. It's not going through your bloodstream. It's not going, in the normal pathway. So it's not giving you the constipation. It's not giving you the sedation. It's not giving you all those things that people hate about the pain medications. And they're able to, have pain relief and enjoy life as well. So that's an option I did not put up there, but that is something that is available in certain places. Any other questions? That question. I'm going to repeat it too.
Me?
Yeah, I'm going to repeat your question when you tell me.
So, is your field or your clinic or your office a place for somebody with chronic migraine pain?
There are things we can do for migraines, but there's only a certain number. A lot of migraines are very responsive to certain medications, and they've gotten very good at developing more specific medications. Those are usually prescribed, and so I'll say about our clinic, part of me coming because there's maybe one other pain doctor up here regularly, and we still struggle to kind of get people in a timely manner. So we don't really manage medications in the clinic. So because a lot of those end up being from medication point of view, I say no from the medications. There's some interventions where migraines, or I'll just say headaches, because sometimes people get classified as a migraine, and it's just because your head hurts, right? And there's other things that can cause it. Sometimes there's things in the neck that can be irritated and can transmit the pain. And I didn't repeat the question.
Yes, okay, you're up.
She said, what about migraines? All right, so there are things in the neck that can cause that, and we'll, again, do those test injections where we might inject some local anesthetic on those nerves that run up into the head. And then sometimes we just do some peripheral nerve blocks. So you might have heard of occipital nerve block is on the back side of your head, but the kind of origin of that is from the C2-3, C3-4 nerves that come up the back. Sometimes people's headaches are mostly in the front. And it's kind of weird, it's called a supraorbital nerve block, where you put a needle, if you feel right there, you can feel a little notch in your eye, and right below your eyebrow usually. There's a nerve that runs through there. Sometimes we can block that and people will feel good for some period of time. Again, sometimes it's like turning your computer off and on. You put local anesthetic on it, the signal's not going to the brain, and the brain starts paying attention to something else. So even though the local anesthetic's going to wear off in an hour or two, it doesn't always mean the pain's going to come back then. And so for some people, each one gives you a longer duration or a greater degree of reduction in pain, and we kind of repeat it. And then of course there's like Botox and things like that can be done, and those are again usually done by the primary care neurologist. Not a lot of them up here, but yeah. Happy to talk to anybody and see if there's something we can do, and if not, again, point you in the right direction. Harry.
So you're a specialist. Do patients have to get a referral to your clinic from their primary care doctor?
Right. So the question is, do patients need a referral to see me because I'm a specialist? Some insurances do require that. We actually require it from a clinic point of view because sometimes pain management becomes a dumping ground. It's like, go see the pain doctor. And nothing's been done to try to figure it out. So we have certain rules to try to create more access for the patients that are coming to see us. If you have to wait because I have to see 10 people and we don't know what they need and we're sending them out, it's kind of a wasted appointment. So if your primary care can send you, and they can send you with some type of imaging or some type of workup of the area, kind of the worst referral I get is just, they have chronic pain. I don't know if it's the neck, the head, the back, whatever, and they show up and sometimes they don't know, and it's like, have you had any imaging? I don't know. So you spend the whole time kind of going back and forth. So that kind of gets people packaged up and gets more for you out of your appointment as well. So when you come, I can give you hopefully an answer or kind of get closer to getting you feeling better as opposed to kind of starting from square one. Because if anybody's come there, the wait right now is a little bit long. So you wait that long to see me. If there's, a visit where we could get something accomplished and make a plan versus just saying, hey, all right, well, let's start from ground one. So it helps everybody if you have a referral and if you have something that's used to work up that area that the pain is coming from. Saw another hand back there.
How do you feel about natural pain management, and do you recommend any?
Can you elaborate? So the question is, how do I feel about natural pain management? And I just want to make sure I'm understanding the question. So when you say natural pain management, what
Without medication, so like dry needling, acupuncture, yoga, stretches, that kind of thing?
that's a whole separate lecture. I feel those things are very useful. I honestly feel like Western medicine has neglected a lot of those things and kind of pushed them off to the sidelines, but I think there's a lot more to, again, energy, frequency, vibration, those types of things. Acupuncture, that's trying to manipulate the different, energy fields in the body. 2 years ago, if you'd asked me about Reiki healing, I was like, okay, you're going to wave the hand. But no, I've come to the realization that you're manipulating energy, you're taking your energy and combining. So I think, short answer is I think natural remedies are very good. I recommend it sometimes. I have people come in and say, I think you just need to meditate. I think you need to relax. You have stress. So I think there's a number of things that, we can incorporate. There's not a lot of people doing it. Some of the insurers don't always cover those things. And so sometimes we have to, again, play with the hand we're dealt with and say, this is what I can do to help you. I think this might help, but we don't have resources for this, that, or the other. But I think that if you can do it without needles, drugs, any of that stuff, I think is best. And I think the mind is very powerful and that it can heal a lot of things. So, absolutely. Question?
So you had a slide dedicated to like foot pain, specifically looking at the bottom, that like burning feeling. Is there any treatments you recommend for that?
All right, so the question was about kind of burning foot pain. So that slide was about neuropathy. So if you see pathy or pati, whatever the end of a word, just means problem. So the nerve has a problem, right? So there's neuropathy. So there's something wrong with the nerve, probably damaged from something. So again, it'd be hard to recommend treatment without knowing the details behind what led up to that or what kind of came from. But there's a number of things. If it's, sometimes it might be a medication. If it's gabapentin and pregabalin, those are pretty good medications without too many terrible side effects. It makes some people tired. There's medications you can start with. There's injections depending on if it's a nerve injury. You can do nerve blocks. And stimulation actually works very, very well for those types of things. But again, we want to make sure those other things have been exhausted and if that's not something that needs to be further worked up. Sometimes people have foot pain because just like you get carpal tunnel, you get tarsal tunnel. It can be, the nerve going to your foot gets squeezed, as it passes by the ankle. And so sometimes the answer is, surgery to open that up and give that nerve more space. So it's a case-by-case basis, but yeah, there's certainly things we can recommend for the neuropathy pain in the feet or the hands. Any other questions?
You're going to be surprised by this question. You mentioned imaging a lot. Is there a value of a PET scan to help you determine treatment options?
I know that's your pet project, but yes, not as common as some of the others, but I do have cases where we don't really know what's going on with it. It's not showing up in the MRI, it's not showing up in that. And so the PET scan can, for lack of a better term, light up the area and kind of say, hey, maybe there's something here that we didn't see here, we can go and approach this. And so it can sometimes show you things that the other imaging might not have shown. And there's different reasons for different imaging. CT is going to be better looking some things, MRI is going to be better looking some things, ultrasound sometimes looking at things. And so everything has a kind of ideal situation for using it. And PET scan certainly has its place. It wouldn't be something that I'd use kind of on a daily basis or frequently basis, but I've ordered PET scans since being here for the past year or so. They had to go to Anchorage, so we need one here. We have one here now. We're working on getting one here still.
Yep, we are going to get one.
Okay.
And I'm taking donations right here.
All right. We're going to get a QR code up there too. Any other questions?
One more quick one. Injections, you talked about in the joints, right? Do you do those in the joints that have already been replaced, already have a total joint replacement, or is that too risky?
Good question. Yeah, so I tend to not want to do them in joints that have been replaced because the replaced joint is a foreign body, and anytime you inject a steroid, like I said, one of the ways it works, it lowers inflammation, but it does that by lowering the immune response as well. So if you put something on something that is more prone to getting infected, you can get an infection in that joint, and only fix sometimes is taking out that joint. And so, but the other workarounds, like I said, some of the radio frequency treatments, if you've had a replaced knee or a replaced hip, we can still target those nerves without steroid. We're just using electricity and heat and energy to try to kind of make that pain go away, right? So those are certainly answers. Yes, we can treat it, but not with steroid typically. I don't, anyway.
Yeah. We'll get David, and then at 8:15 we'll call it.
What do you like about Fairbanks?
The people. That's easy. The people. Everybody's nice. I mean, well, probably everybody's not nice, but I've lived in a number of places. I lived in New York City. I lived in Northern Virginia, and so, the people are way nicer and friendlier here, and they seem to really appreciate having people here, helping people. I was talking to someone today, And they said they had to go and clear their yard. They create a barrier, I guess, for the potential for fires. And they said, oh, everybody comes out and they all help. And so it's kind of a community where you kind of look out for people. And again, people also appreciate what you do. You know, I've been places where I'm like, oh, doctor, you're taking too long. And I was like, oh, okay, I take as long as people need. Sometimes I need longer, sometimes I need less. And there's some doctors that cut you off. You're like mid-sentence, oh, gotta go. And so that's not me. And here, I guess there's not a lot of other options, but I'll tend to listen to people. One, because they sometimes have interesting stories, but otherwise they also play into why they have pain. And, you know, one of the things I like about anesthesiology is they say, hey, you actually like to talk to people. Sometimes I do, sometimes I don't. But it's like, why do you want to go into anesthesia? You know, you don't really talk to people. And I say, well, if I come in as an anesthesiologist and you're about to have surgery, that's a pretty major thing in your life, right? If I'm a robot, that's, you know, not really gonna make you feel comfortable. But if I can connect with you and talk to you, then, you know, you're gonna go into surgery, your you know, cortisol, your stress, all that's gonna come down, and it makes you hopefully have a better outcome. So I felt like it's a very important interaction with that. And then same thing here, like I said, coming here, people, I get that energy back here that people, you know, make me feel comfortable, lower my stress level. And so, you know, we want to do everything we can to do to help them. So we'll have patients that come in. This one, I think he came in, somewhere he had to catch a flight here. And it's like, look, we got to figure out how to do something for him today. We can't say, go home, we'll figure it out. And so, you know, you want to return that to them because people are happy to have you here. You want to make sure you know, are happy, make them happy to be here, right? And so it's the patient experience is good and the doctor experience is good too.
So this summer, we had Dr. Gay for chronic pain, and it sounds like next summer, music in the garden, jazz, blues.
Sign me up. Sign me up. Yes.
Big hand for that.
Thank you.